Greetings, everyone. Thank you for inviting me to speak at this 26th anniversary of Pedicle Club Indonesia and Indonesia Orthopedic Spine Society meeting. And today we'll be talking about lumbar fusion in spinal endoscopy, this integrated video conversation and meeting discussion. So we'll be doing a live example. In Singapore, we don't really have an opportunity to allow to film real life in theater. So I use integrated cadaveric workshop together with some intraoperative video to make it comprehensive for participants. I'm self-introduction. I'm a consultant orthopedic surgeon. I practice in Mount Elizabeth Hospital and Mount Novena Hospital. These are my clinics. I'm actually a private orthopedic spine surgeon. 80% of my spine surgeries are done using endoscopy, and half of them uniportal, half of them biportal. More and more biportal in these days. And most of them stenosis, discectomy, fusion, and cervical thoracic cases. These are my conflict of interest. It is relevant for this topic. Essentially, for fusion, we need three basic requirements: a good preparation of fusion bed, bone graft, and fusion device insertion, immobilization, and then hopefully we correct very well the sagittal coronal and transitional alignment. There are several approaches in bipolar endoscopy. Generally, the two main common approaches will be that of the UBE fusion, which use the transforaminal extended transforaminal window, and what we call extreme lateral T-lift, which is essentially very much at the lateral aspects of the facet joint. Of course, both of them involve removing the facet joint. In this step-by-step guide, I also would like to credit my international fellow from China. He's from Nantong. He's also called Mr. Dr. Wu, or called Dr. Wu Chunshuai. So some of the slides are prepared by him, and this essentially step-by-step guide on UBE lift. So let's go to the case. This is a 48-year-old male. He has lower back pain and left lateral calf pain for 3 months. He have tried physiotherapy, but had not gotten better. His examination shows that he has a power fall in the left L5 and decreased sensation over the left L5 as well. His strict leg raise is negative. In the MRI, you can see that he has a significant foraminal stenosis, left side more than the right side, in the L5S1, as well as a grade 1 spondylolisthesis. This is a lytic spondylolisthesis. In the flexion extension film, you can see that there's a greater translation of the L5 over S1. After informed consent, the patient agreed to go for a left-sided lumbar 5, sacral 1, UBE, transforaminal lumbar interbody fusion. This setting that I have done in Punlei, but it is very similar. We have the patient mark. First, starting at the correct this level, I would have done a lateral view to ensure that end plate is perpendicular to the ground as far as possible, and then mark the midline, lateral particular line, and then over the in the left side, we will have a slightly higher portals, will be the upper pedicle of L5. And in the right side will be the lower pedicle of L5S1. So we do the AP lateral view to confirm the finding, and we insert the endoscope. After we insert the endoscope, we have to essentially identify the Wu's point, so-called, is described in the literature, that is in the spinal, in the middle medial part of the facet joint close to the spinal laminar junction, with the overlap of the inferior articular process and the superior articular process medially. And then we identify that of the lateral aspect of the superior articular facets, we have to release the capsule, and then using a chisel, we can remove the um, inferior articular process first to expose the superior articular process. It is challenging to sometimes remove the entire inferior articular process. So sometimes we remove them piecemeal. As you can see in this video, we remove the inferior articular process piecemeal, as you can see using a chisel. Using a chisel is a good tool because we can harvest the bone blocks in very big pieces rather than that of using a drill where they will be drilled to bone dust. It will be good to use a kind of a retraction device. It can be a metallic one, it can be a plastic one. In this case, we use the plastic one. So essentially, we now have removed the lateral aspect of the inferior articular process, and now we remove the medial part of the inferior articular process. After you removed completely the inferior articular process, on the medial part, you will be able to see some sort of the superficial flavor. And then we do a superior articular process facetectomy. It can be done using the chisel in the combination of chisel kerosene. We can remove the superior articular process. And this is the last bit of the inferior articular process. Excuse me. And then you can see the ligamentum flavum essentially. And subsequently, we remove the superior articular process. Upon complete removal of the superior articular process of S1, then you will be able to see the traversing nerve root. Sometimes we leave the medial part of the ligamentum flavum to protect the traversing nerve root. It's entirely up to the surgeon whether you want to expose the traversing nerve root altogether or just removing part of it. So after that, we cleared up and then we clean up the pedicle. Sometimes we need to just trim a bit of the superior edge of the pedicle to ensure a more smooth transition of the cage insertion. So as you can see, we are slowly detaching the ligamentum flavum and removing that of the inferior articular process. You can use a chisel or you can use a kerosene. Depends on your which one you're more comfortable with. The beauty of the endoscopic fusion is that throughout the process there is very little blood loss because the saline pressure essentially decrease the for all those microcirculation bleeding. And then subsequently, we can be removing the ligamentum flavum. It is quite natural for the ligamentum flavum to drop off. That's of the lateral edge of the traversing nerve roots once we have removed the superior articular process and the inferior articular process. At this moment of time, we can make a decision of whether we want to do over-the-top decompression on the contralateral side, typically following the ligamentum flavum to the opposite side. In this case, this patient, as you can see in the previous MRI, have no significant central or lateral recess compression, as it is a lytic listhesis. More importantly, this of the reduction of the listhesis as well as that of the decompression of the exiting nerve root. In the patient with grade 2 and above spondylolisthesis, it's advisable to remove the both facet joints so that when upon reduction, there won't be impingement of the exiting nerve root of the contralateral side. This process can be quite time take some time when we remove the ligamentum flavum, but this is a real time, and we can remove them gradually. Sometimes there will be creeping of the muscles of the above, so we tend to just get underneath it and then remove them accordingly. We assess whether after we remove the facet joint, there's sufficient space for the cage insertion. If not, then we can enlarge them further by using kerrison or drill. After we remove the that ligamentum flavum, will be exposing that of the disc space. In this case, there's the listhesis. We confirm that by using the lateral view of the C-arm and then see whether we are at the correct level of the disc space. Finding the correct level of this is important, so we use lateral view to find the disc cut. You can use the chisel gently also, but do not go too deep, so as to create insufficient space for the cage to be inserted. In a grade 2 listhesis, such as this case, sometimes the rounded edge of the sacrum can be a impingement or can be impeding the entry of the cage. Hence, you can use the kerrison to open it up a little bit over the S1. I suggest when we start doing endoscopic fusion, do not do a grade 2 or grade 3 listhesis. I think grade 3 listhesis is generally a very challenging case. Grade 2 listhesis is possible. So after we open up the end plate properly, you can see that we can enter the first trowel. And then after we enter the first trowel, we can use this forceps as well as a shaver that we use in traditional open surgery to prepare the end plate. I think use the smallest dilator first to find a good trajectory before you, under CM guidance, of course, to before you enter or using the shavers and larger dilators. Sometimes in cases such as this, which is a grade 2 listhesis, the disc is rather empty. There's not a lot of disc inside, but the challenge is to get the correct trajectory without violating the end plate. So now we can use forceps to clean up. If we use the radio frequency, then we have to only uh, basically apply it to the posterior third where the fusion doesn't necessarily take place. And then now we insert the cage inserter, and then subsequently you can use it to bang cage in. As you can see from this demonstration in Pune, we are using metal retractor to retract the exiting nerve root, find the correct trajectory, and then prepare the disc. Okay, it's all under direct endoscopic vision. You can see the edge of the traversing nerve root, so it's very clear, and then we can insert the cage glider. Finally, with a good assistant, in this case, Caden, speak and insert the cage. And in Pune, we were doing an external, so we have to gradually horizontalize the cage. But in the actual case, when I did that in Singapore a couple months back, we actually just insert the cage directly using a T-lift cage that we use in open surgery. And then we insert the percutaneous screw insertion. I was contemplating whether I should reduce it fully. I think there's a couple of considerations. It got a very small pedicle. This size of the screw is 5.5. The small pedicle actually is more of that of the height, which is the height. Capillary caudal diameter is really short, so I would rather not give too much stress for the screw so that I reduce it to grade 1. The beauty of this surgery is that the patient usually do very well. In post-op 6 hours, they can walk. Done many of these cases have not yet needed to transfuse any patient. Most of them are discharged on post-op day 1 or 2. Okay, thank you very much for everyone to listen in to about how we do this endoscopic fusion. Have a great meeting, and I see you in the meeting in my coming talks and moderation session. Thank you very much.